Hi, this is QD Clinic. I'm Jack Cush with Room Now. QD Clinic is brought to you by Room Now Live, March 2021. Be there. Great rheumatologists like us go to great meetings like this. Our case today is enteropathic arthritis. Is it the Crohn's or is it the arthritis? So we have a 35-year-old man who's had Crohn's disease for better part of 12 years. It's been difficult to control. About 6-7 years ago, he started getting mostly peripheral arthritis, but then more and more back arthritis. Turns out he's HLA-B27 positive. He's got peripheral synovitis, and everything's going wrong. He's been tried on almost everything. He's been on multiple attempts at TNF inhibitors. He's been on background steroids, background use of mesalamine, sulfasalazine, oral DMARD-like medicines. He's currently on azathioprine and ustekinumab because he has failed all the TNF inhibitors and vedolizumab, and he's really not doing very well. So the question is, now that he's not doing well, how is a rheumatologist to be involved here? I think there's a very simple approach to this, even though this is horribly complex. The bottom line comes from a story during my residency. I went and did a rotation with the famous Dr. Thomas Metzger at the University of Pittsburgh. And while we were doing our daily rounds, we went and saw a patient, an inpatient, with ankylosing spondylitis and Crohn's disease. He was admitted because he was writhing in pain and he was out of control. His Crohn's disease was perfectly under control. And what I learned from that is while Crohn's patients can get arthritis and spondylitis, it is the peripheral arthritis that parallels the activity of the gut disease. So as his Crohn's goes, so will his peripheral arthritis, hands, knees, and feet, etc., toes, fingers, asymmetric oligoarthritis or symmetric polyarthritis, whatever. So meaning that if you cut out his gut for horrible colitis, his arthritis will go away. On the other hand, if he's B27 and he's part of the 20% or so of Crohn's patients who have spondylitis because of B27, there'll be no effect of disease control in the gut on his spondylitis. They have to be treated separately. So in this particular gentleman who's doing poorly right now, on Stelara, good for gut, good for skin. He doesn't have skin. So-so on joints, and azathioprine, presumably good for both. What is he complaining of? Well, his joints are active, mostly peripheral, not axial. He has a few swollen joints, but his gut is out of control. He's still having bloody diarrhea and not doing well. So the bottom line is he needs to have whatever's necessary to control his disease. So maybe he needs steroids right now to get him acutely under control. When he's been given steroids in the past, guess what? His peripheral arthritis gets better. But is it because we gave him peripheral steroids or because we controlled his gut disease with steroids? That's a really important consideration here. So they are running out of treatment options here, and it's possible he may do better on ustekinumab with the addition of maybe a drug like cyclosporin or tacrolimus. Those haven't been tried yet. Maybe he needs to be on leflunomide, which hasn't been tried in him at all. He did not tolerate methotrexate very well. He could get tofacitinib, but as you know, tofacitinib has been studied and has been approved for use in ulcerative colitis, not in Crohn's disease. There are some who believe you shouldn't give Crohn's disease JAK inhibitors. Man, this complex, this difficult, I might if push comes to shove. Again, but I want you to take away from this case is that it is the peripheral arthritis that runs in parallel and is connected to the enteritis or the uncontrolled colitis. Control one, you got the other. For Room Now Live, I'm Jack Cush. Talk to you next.